Excellent. Well, thank you all. Thank you for the kind introduction. And for the next 10 minutes or so, we'll discuss ECMO, the evidence we have for ECMO in pregnancy, and some management approaches. I have no disclosures. So what we know about ECMO in the peripartum period is really, limited to case series, case reports, and whatnot. And we'll just go through some of the existing evidence quickly, discuss some management, and then as a way to set the stage for the session. So in a literature review looking at peripartum ECMO, 67 patients total from 2009 to 2014, 44 of whom were pregnant. By far and away, and similar to adult ECMO in general, the most common indication is ARDS, okay? But ECMO has been used for a variety of severe conditions during pregnancy and the peripartum period, including amniotic fluid embolism, peripartum cardiogenic shock, acute PE, even cardiac arrest and ECPR, often with great success. The majority of these patients we have reported have been supported with a VV configuration, representative of the type of illness that they have. And, obviously with likely a publication bias, in play, we do have a very nice reported survival of 80% in the patient with a fetal survival of 70%. Looking specifically at peripartum ECMO during the H1N1 pandemic, which is where a lot of that literature series and evidence actually originates from, is a series of 12 peripartum patients from the Australia-New Zealand group. Oh, it looks like Siri wants to be involved as well. Siri's on it. All right. And an average age of 29, 50% of whom were also obese. Again, mostly supported with VV ECMO given the nature of their ARDS. What we see is that compared to a non-peripartum population, outcomes are really identical. This is true of survival, with survival of 66%, as well as the rate of complications, bleeding, infection, and other complications that had been described. Okay, so very similar to our non-peripartum population. Now, looking specifically at ECMO during pregnancy, we also have several reviews of patients, about 45 patients total over 26 studies. Average gestational age of these patients is about 26 and a half weeks at the time of ECMO cannulation, with an average ECLS duration of 12 days. What we can see is that survival, similarly for this pregnancy-limited population, is quite good, over 75% survival overall, with quite impressive fetal survival as well of 65% in all comers. Now, when broken down and by the etiology of the decompensation, regardless of whether the patient decompensated due to respiratory and cardiac problems, that survival is pretty good, right? It's at least 75% overall. However, fetal survival drops off substantially, down to 25% fetal survival when there becomes a concomitant cardiac issue. Again, likely reflecting the severity of illness, the multi-organ involvement that is occurring in those patients. Now, in our series that we published several years ago, looking at the more modern experience of ECMO in pregnancy, 18 of our patients at our center at Columbia were cared for with an average, pre-ECMO blood gas, 7.2, 52, 53, quite a sick population. While the majority had ARDS, 3 also were placed on ECMO as ECPR. Others had, a variety of, pregnancy-related indications, including PAH and acute PE. While the survival was also very similar to what we know to be reported, what was most impressive, as far as we were concerned, was that the fetal survival, particularly fetal survival after viability, was actually 100%. And this was without any severe or obvious disability in the babies that were ultimately born. 2 of these patients delivered on ECMO, 1 delivered following a planned ECMO decannulation. And so we were able to support these women through their pregnancy at times and really allow for a good fetal outcome. Okay. Now, what about COVID-19, right? Specifically, this is an evolving area of study, and we're gaining more evidence, as time goes on during this pandemic. But we do know that there seems to be an increased risk of pregnancy-related complications in patients with COVID-19. Compared to non-pregnant patients, we see an increased risk in the pregnant population of ICU admission, of invasive mechanical ventilation, of ECMO, of needing ECMO, and also of death. Okay? Looking at this ELSO series that Dr. Angus mentioned in the plenary, we know that 2% of the ELSO registry patients overall during 2020, during the 2020 year of the COVID pandemic, were pregnant patients. Okay, that was 100 patients total. And we did not see an increase in mortality over time as we did with the population in general. When looking at more specifically at this 100-patient group, in a review just recently published by O'Neill and colleagues from January 2020 to April 2021, out of this 100-patient pregnant patient group supported with ECMO, compared to the non-pregnant patients, what did we see? Well, those with severe COVID on ECMO were, in general, younger, 32 years versus 49 years, more likely to be a racial minority, and overall have fewer comorbidities. So pregnancy definitely put them at risk in whatever way. They did have similar pre-ECMO P to F ratio, 68, pre-ECMO PEEP of 14, and similar rates received pre-ECMO prone positioning, over half, okay? And again, similar rates of complications to the non-peripartum or non-pregnant population. Despite having this very severe level of illness, we did see an improved survival in this pregnant group compared with a propensity score adjusted comparator cohort. So 84% survival in this pregnant group compared to 51% survival in these sort of propensity score match patients, and possibly reflecting the younger age of these people, possibly reflecting some other unmeasured factors. And looking at peripartum ECMO in general, not just during COVID, not just in pregnant patients, we have seen very low rates of, actually no rates in this small case series at least, of any fetal transmission. While this has been demonstrated to occur, it seems to be quite a rare occurrence and is not a typical risk for the average patient. Based on some of this data and the kind of overall global experience of COVID-19 during pregnancy, the Society for Maternal Fetal Medicine has endorsed the use of ECMO in pregnant or postpartum patients with COVID-19. They actually recommend that ECMO should not be withheld from these patients in whom it may potentially benefit, and actually endorses the use of ECMO less than 32 weeks gestation in patients with refractory hypoxemia to facilitate in utero fetal development. And I think this is the most interesting of these guidelines, really suggesting that, hey, and as someone who's decompensating or is at risk for fetal distress or showing signs of this, we can place these patients on ECMO to not only help the patient in front of us, but actually help that fetus to mature to a time where delivery may be more advantageous. We'll speak briefly now about the management of the principles of management of pregnant patients on ECMO. So this should be a similar approach to our non-pregnant patients, right? The principles of ECMO still apply. So using a long rest approach to mechanical ventilation, mindful of in consideration of the fetal demands, while caution to avoiding complications, including things like bleeding and DIC, which albeit in the H1N1 experience was not any higher, have been inconsistently reported to occur more frequently in some other small series. Just as a reminder, uterine artery blood flow, uterine artery oxygen content, hemoglobin level, and O2 stat all are determinants of fetal oxygenation, right? So things not only hypoxemia in the patient, but impairment in gas exchange, hypotension, vasoconstriction, and also uterine contractions can really impact placental DO2, which is what we care about for that developing fetus, okay? So our goals when taking care of these patients on ECMO, maintain a PaO2 greater than 70, and an O2 stat greater than 95% to ensure adequate fetal oxygenation. This is based on scant but present, oftentimes animal data. Try to maintain a pH in the normal to mildly alkalotic range. Why is that? Well, especially as pregnancy develops, or progresses, we have the development of a mild respiratory alkalosis in these patients with an average CO2 of 30 to 32 millimeters of mercury, okay? In a pH less than, in a mildly alkalotic pH. And we know that fetal CO2 clearance is determined by a gradient between the maternal and fetal circulation, okay? So maintaining this mildly alkalotic state, maybe with a mildly low CO2, will help ensure that continued transfer of CO2. We want to make sure that we use a long rest approach to ventilation in these patients, but be very mindful if that patient seems to be requiring high levels of PEEP. Because at higher levels, and it's been shown to be greater than 10 or so, we run the risk of decreased cardiac output and therefore impairment in placental DO2. Hemodynamically, we should maintain a physiologic map, greater than 65 while monitoring our traditional markers of hypoperfusion, including lactate, creatinine, transaminases, and evidence of fetal distress, as we'll hear about in one of our later talks. Low-dose anticoagulation is also recommended, as it would be in our non-pregnant patients, okay, while being mindful of the risk of bleeding, especially in that peripartum period, pre or post-delivery, and particularly post-cesarean section if that is needed, as we have seen many cases of abdominal compartment syndrome occur, okay. And I'll just wrap up here with one note on ECMO cannulation. Both dual site and single site VV ECMO has been used in patients who are pregnant with success. At times there's been concern that a dual site or ephemeral configuration may result in decreased ability to have that venous drainage that we want due to the compression of the IVC from the gravid uterus. That may or may not be a problem clinically, but if it does occur, we can resolve that with a 15 to 30 degree left lateral tilt, okay, relieving that pressure on that IVC. So in summary, ECMO is used and can be beneficial in patients with excellent maternal and fetal outcomes, being mindful of the considerations that demands of the fetal circulation. Thank you so much.
Thank you for inviting me here today. It's really an honor to be in this session. And so I'm going to take a different slant on pregnancy, and that is, as a pulmonary hypertension specialist, what happens when these patients do present pregnant. And I don't have any disclosures except to say that it really is something that even frightens most of us when we encounter one of these patients because of the very high risk of maternal mortality, up to 50% in some series. And despite all of our medical advances, that has not really changed much over the last several years. There's also a high risk of fetal mortality, as you can see, and these mortality can occur for the mother, not just during the pregnancy, but even in the postpartum period. In fact, some series report that that's the highest risk time for the mother with respect to heart failure, sudden death, and hypercoagulability, PE and DVT. So despite all of these advances, the recommendation, even ones that were just published a month ago by the European Respiratory Journal, are that you should avoid pregnancy and terminate early if able for patients with specifically group 1 PAH. So this doesn't relate to necessarily heart-related PH, but specifically group 1 PAH. And despite these advances, there are currently no standard management practices because these cases are so few and far between. But we have garnered enough experience to know that mechanical support now is a vital tool in our toolbox, along with medical therapy, to manage these patients successfully through pregnancy. So what I can say, and if you take one thing home from this brief talk, it's that a multidisciplinary team is required. And again, adjunct between medical and mechanical support, or even mechanical support backup, is critical. And bringing your team together early on in the pregnancy, as soon as a PH patient presents with pregnancy, is really important because there are so many physiologic changes that occur that these patients can decompensate at any point along their pregnancy. And so just very briefly, I'm going to highlight a couple of those physiologic changes to kind of give us a better picture of why these patients are at such high risk. So we know that as the cardiac output increases substantially during pregnancy, for someone with a normal right ventricle and pulmonary vascular bed, that's not necessarily a problem. But when you have a patient who's got a high pulmonary vascular resistance and starting with RV failure, when you put that demand on the heart, that is not well tolerated, and that gets worse as the pregnancy goes on in time in the second and third trimester. Further, you can see here, this is a wonderful depiction of some of the other metabolic and physiologic derangements of pregnancy that impact the pregnant woman with pulmonary hypertension. It's a nice summary slide. It talks about the high, and also the influence of hormones on these factors. So a fall in SVR, a rise in cardiac output, oxygen consumption, hypercoagulability, and even an increase in blood volume without the appropriate rise in red cell mass is going to lead to physiologic anemia. These all put a stress on the heart. They can lead to RV dilation, RV failure, pulmonary embolism. If a patient happens to have a congenital systemic to pulmonary shunt, they can have profound cyanosis because that placenta is like, really impacts the PVR to SVR ratio. And then on top of that, were these patients to survive to delivery, you're then going to have a sudden increase in venous return and loss of blood volume, potentially exacerbating things even worse. So this is really to paint the picture of why we worry about these patients so much, and what, kind of shift now as to what we offer them in the current era. So this is a nice picture from the recent guidelines, but just to show you what there are three main pathways that we use for medical therapy. And again, this is adjunct if and when we need to use mechanical therapy, but some highlights here are one, you really do need a pulmonary hypertension specialist on the team here to manage these patients so that they know which medications are safe, like the prostaglandins, as well as which medications are not safe, like the endothelin receptor antagonists and guanylate cyclase stimulator inhibitors. We've also used PDE5 inhibitors in pregnancy safely, and again, there are no large studies looking at any of these because there are no large studies looking at very, big cohorts of pregnant women with PH, group 1 PH, that is. And then, of course, if the patients are already on anticoagulation, we want to put them on a safe anticoagulant, and I have gotten in the practice of anticoagulating these women postpartum for up to 6 months because they're still vulnerable. We have lost patients in the early days from PE following pregnancy after getting through a successful delivery. So some of the key factors that you need to think about, and these are practical factors that I think are really important, are sort of the how you're going to monitor the patient, the timing and mode of delivery. And I can tell you when we have a patient that presents pregnant, this is a conversation that starts immediately. And we pull together teams of high-risk OB, our ECMO team, and that may seem extreme, but it won't when you see a couple of the cases. Anesthesia, pulmonary hypertension team. We do very frequent monitoring in the beginning monthly, then biweekly, weekly by the third trimester, and of course admit patients if they have any signs of clinical worsening. And the optimal timing for delivery, it's still out for debate, but in general, you want this to be an elective delivery, if possible, with all hands on deck, usually during the daytime hours, and having resources available to you. And also, we've taken the strategy of not pushing the patient, obviously, fully to date, but really wanting that window where the lungs are mature in the fetus and the mother is clinically stable, obviously earlier if they're not. There's also a lot of debate on the mode of delivery. There are some guidelines that say a cesarean section is better than a vaginal delivery, but I think, again, jury is still out on that. What we do know is that an emergency section is not well tolerated in these patients, and so you want to, again, plan for elective if you can. Look at the patient's obstetric history to see what, in fact, you can offer them. If they're previous C-section, you may not have a choice. But also look at this likely success of doing a vaginal delivery, assisted vaginal delivery, and how sick the patient is at the time of delivery. The other key feature is that we want to avoid general anesthesia at all costs, again, because of the impact it has on the right heart, and so typically we'll go with spinal or epidural anesthesia, but you should also know that you're not out of the woods there because these patients, again, if they drop their systemic vascular resistance and blood pressure, they can get quite ill, and so you really want your anesthesiologist to be on board and making sure to be maintaining a good blood pressure. So now I'm going to move specifically into why I think mechanical support has such a critical role in these patients, supporting these patients through a pregnancy, along with our medical therapies. And I'm going to highlight a few examples of cases, and I think I'll bring out the key points as I do that. As we know, typically for pulmonary hypertension, we're thinking about veno-arterial support because the RV has failed and you want to support the cardiac output. And there are some exceptions in some instances where veno-venous support might be appropriate for those of you who take care of patients with congenital heart disease and large shunts, or in the instance where there's an identifiable trigger for hypoxic respiratory failure, such as a PE or pneumonia, for example. So I want to run through a couple of cases quickly. This one was published a few years back with our team at Columbia. Okay, we're going to run through them very quickly. This was a 29-year-old female who had a patent ductus arteriosus. So for those of you who forgot what that is, hopefully not, it's a connection between the pulmonary artery and the descending aorta. And these patients, imagine, during pregnancy could get very blue in the lower portion of the body. And that's exactly where the fetus is receiving supply due to the decrease in SVR from the placenta. And so here's a woman who had a PDA, presented quite sick with symptoms, systemic PA pressures. We adjusted her medications and started to develop profound cyanosis, postductal or in the lower body, and the fetus started to get growth restricted. And this is to Kara's point there in terms of what we can do to support the fetus as well. What we did was we cannulated this patient as she started to get closer to term with a dual lumen veno-venous cannula, and supported her with an oxygenated right to left shunt. And what you can see on the bottom left of the panel is that the fetus, the lower extremity sats were much better, and that was what the fetus was seeing. This woman unfortunately delivered shortly thereafter and did not tolerate induction of labor and ended up having to have a stat C-section. Of course, I said we want to avoid that, but at the time, the ECMO team put in an arterial sheath in case we needed to convert to VA ECMO. We were able to support her with VV ECMO temporarily, but she had some post sort of delivery complications, including some intraperitoneal bleeding, and ultimately was decannulated, but about a week or so later, she went into respiratory failure, was supported with VA ECMO, and ultimately was decannulated and survived a discharge. Unfortunately, at home, 3 months later, she passed, and that's one of the other messages, that these patients can get worse even if they survive through the pregnancy. I also want to mention just this case of an Eisenmenger patient who had a relatively late termination, 22 weeks. She presented and was counseled to terminate. She elected for the termination. We had ECMO team, everybody on standby, supported her with nitric oxide and iloprost, and seemed to be going okay until she actually, after the planned abortion, when she had uterine contraction and went profoundly hypoxic. So she, thankfully, we had been prepared and went on VV ECMO and survived, and ultimately was weaned off and sent home. But this is just to show you that even a termination for these patients can be deadly. And then I'm going to go very quickly through this last case, really to highlight that there are a whole host of, patients aren't all the same. Probably our best adjusted patients are the calcium channel blocker responders with pH. Sometimes they have normal pressures, but we should still be mindful that they can really have just as, poor a course as other patients. This was a young woman who presented to me having done relatively well. She presented pregnant and started to have worsening echocardiogram and worsening shortness of breath. She was ultimately delivered with quote-unquote backup ECMO, and I don't think the ECMO team loves me using that term, but really they were there on standby with sheaths and ready to go for this delivery. Thankfully, she didn't need it, and all is well, until she presented to me again last year with her second pregnancy. And I hadn't chartered that territory, but the ECMO team again was on hand, ready, in case her second pregnancy didn't go as well as the first. And in fact, she too did not require being on ECMO, but had sheaths placed, and thankfully, because on, say, postpartum day 3, she did take a little bit of a turn for the worse, so we tend to keep the sheaths in for a few days. Then she started to stabilize, and once again went home with baby. I should mention all of these babies did well, aside from the planned termination. This is not published, but this is just to summarize in 5 women over the last few years, specifically with group 1 PAH. We also had a CTEPH patient. While they've done well, that is with a team, a very large expert team, including our ECMO team. Only 2 required actual cannulation to be on ECMO support, and 2/3 required backup, but I think it is having those tools in your toolbox that enable them to do so well. So to summarize, pregnancy and pH is really a multidisciplinary management to avoid catastrophic outcomes. It can be managed well, but you've got to work together, and even the most stable patient can decompensate. So you really get your ECMO team involved early is my best advice for managing these patients. Thank you.
Thanks very much, and it's such a pleasure to be here. Thanks to the organizers, especially Kara, for inviting me to be here. I feel like I formed this virtual connection with a number of people, including Kara, Ram, Graham, and others, through a couple of editions of the Red Book through the pregnancy chapter. And it's lovely to meet everyone face to face and know that you really exist. And one of the other people in this little team is, of course, Farah from Leicester in the UK. And as Ram said, she can't be here today. She's been quite unwell with COVID pneumonitis, unfortunately, but she's getting better, which is great, but can't travel. She's kindly sent me some of her slides, and I'll try and do them justice. I don't have any disclosures apart from that. So what I'll do in the next little while, very briefly, is to touch on some relevant changes in cardiorespiratory physiology in pregnancy, talk a little bit about the uteroplacental and fetoplacental circulation as it pertains to ECMO, and then moving on to a little bit about fetal monitoring in this context, and then how we would plan and facilitate a safe delivery for these patients. So the physiological changes, as we know, can be divided into anatomic and functional, the important anatomic ones being the elevated diaphragm and the widened subcostal angle, and the important functional ones being a reduction in functional residual capacity, predominantly due to a decrease in expiratory reserve volume, bringing that closer to the lung closing capacity. There is also a decrease in carbon dioxide from an increase in minute volume, from an increased respiratory rate and tidal volume. And of course, with advancing pregnancy and the growing fetus, there's an increase in oxygen consumption and increase in CO2 production as well. The cardiovascular changes, so there's an increase in stroke volume and heart rate, of course, both of which increase cardiac output, which increases by up to about 45% at term. Additionally, blood pressure drops in the first 2 trimesters related to the decrease in systemic vascular resistance, but this normalizes in the 3rd trimester, and pulmonary vascular resistance decreases as well. This is just a picture showing the uterine size by weeks of gestation, suggesting how significant this growth would be on the abdominal and thoracic cavities for our patients. So briefly about the uteroplacental circulation, the uterus is supplied by an anastomosis between the ovarian and uterine arteries, forming the arcuate artery that wraps around the uterus, and penetrating branches via the spiral arteries supply this space that's called the intervillous space, which is kind of the exchange zone between the maternal and fetal circulations. It's thin-walled and low pressure. It's a blood pool that contains about 500 mils of blood, and the 2 circulations run in parallel. There's no mixing of blood, but there is transfer, of course, of gases and nutrients between the 2 circulations. The uterine blood flow increases to about 15% of cardiac output at term, and normal non-pregnant state it's only about 3%, so it increases vastly at this point. And in terms of the gas exchange that occurs, the diffusing capacity of oxygen is very much dependent on the transplacental gradient of oxygen between the 2. And we're all aware of the double Bohr effect that occurs at this placental level, where the hemoglobin oxygen dissociation curve in the mother shifts to the right because it takes up carbon dioxide from the fetus, gets acidified, and then gives up oxygen on the fetal side, while the fetus, having just given up that carbon dioxide, moves its oxygen hemoglobin dissociation curve to the left and can take up more oxygen. So this is really useful for oxygen transfer to the fetus. And similarly, we have the double Haldane effect, which exchanges carbon dioxide very effectively from the fetus to the mother as the maternal blood gets deoxygenated. Secondly, the fetal hemoglobin concentration is significantly higher, about 17 grams per deciliter, so has a much increased oxygen carrying capacity. And if there are any other compromises, the fetal circulation can actually increase the oxygen extraction ratio. So as you can see, the fetus is very well protected by all of these mechanisms. And this kind of suction of energy and mopping up after them continues for the next 20 years or so, as you know, with all the give in one direction and take in the other direction. So just moving on a little bit on neonatal survival and viability. This is a chart showing survival in early gestations, and you can see that up to 25 weeks, there is a significant mortality at 6 months. And this one showing outcomes and severe disability, so survival and severe disability for those early weeks of gestation as well. And this is, of course, for mothers who are healthy. So you can imagine a mother on ECMO being really sick. The survivals would be expected to be a lot worse in these early gestations. And so the age of viability is considered about 25 weeks. And thereafter, obviously, protecting the fetal needs becomes part of our algorithm when we're looking after these patients. These are some of the fetal monitoring modalities that are available out there. Of course, a fetal heartbeat is easy enough to get with a handheld Doppler or an ultrasound and is present from 16 weeks onwards. The thing is, it may not be that relevant to monitor at this point because whatever you find won't really change your management until the age of viability. The ultrasound scan gives you much more information, especially when coupled with Dopplers of the umbilical and fetal circulations. And this can also give you anatomical information like the location of the placenta or any other abnormalities, and can monitor fetal growth as well. Farah tells me from the ages of sort of 23, 25 weeks onwards, doing one of these a couple of times a week or even more frequently whilst the mother is on ECMO is probably the best way to go. There is the CTG or the cardiotocograph, which predicts acute problems in the fetus with fetal hypoxia or acidemia. Problem being it's hard to interpret in a sedated mother. And secondly, you really need to have a trained midwife or an obstetrician to interpret this. And having done that as well, if there is any problems, it has to be coupled with a very urgent delivery plan. So it's not used that much in clinical practice, although it can be monitored remotely. The good thing, however, is if the mother is doing okay with reasonable physiology, oxygenation, and circulation, it's very unlikely that the fetus would be suffering. As I mentioned, they're highly resistant organisms, those ones. So that moves us on to when should we actually deliver. And it, again, really revolves around the maternal status. So what the indication for ECMO is, how long the mum is expected to be on ECMO, are things getting worse with clinical deterioration, vasopressors going up, etc. Things like comorbidities in the mother as well might play into that risk-benefit calculus. And obstetric complications like ruptured membranes or chorioamnionitis, preeclampsia, all of these things might force our hand into an earlier delivery. And the fetal stage, of course, plays into it, but not as much. So it's really quite a complex group of things we have to look at when making these plans. And that's why, as Erica mentioned as well, this is really a team sport, taking a lot of experts into consideration and getting their expert opinions, including obstetric and neonatology teams, along with our ECMO teams. And really important to have a delivery team in place with named individuals who know what their roles are and can, at the drop of a hat, be activated, summon their teams, and get going. So more so than others, we're all used to in intensive care working with multidisciplinary teams, but this involves working with teams we may not normally interact with, and so it's really important to get this kind of conversation happening right. And about the timing of delivery, really it might evolve as the pregnancy progresses, and this discussion is ongoing as the pregnancy advances. As Kara said, we know that ECMO therapy in early gestations results in good outcomes both for the mother and the fetus, and continuing supporting the patient on ECMO in the interest of the fetus is something that's quite reasonable to do. However, if the pathology in the mother seems to have recovered, the lung pathology or the cardiac pathology, whatever the patient's gone on ECMO for, and if it was a non-pregnant state, you would expect that that patient would be decannulated, but there are still problems with oxygenation, circulation, which are thought to be related to the physiological changes of pregnancy. That might be a reason to consider delivering that mother. This is Emily's meta-analysis where she looked at 358 peripartum patients. Out of them, about a quarter were antepartum or pregnant. Majority of them were delivered by cesarean section, and only about 10% of them were delivered whilst on ECMO. So spontaneous vaginal births are possible whilst on ECMO and do happen, and certainly if, in case of fetal death, it's appropriate. However, induction of labor in this context is fraught with problems, can cause fetal hypoxia and acidosis, problems for the mother with oxygenation, blood pressure, and pain management. And in any case, you'd have to have emergency operative delivery ready on standby, waiting to go. So most units, therefore, would electively go for cesarean section, as in PAH, where you have the relevant people available, it's in daylight hours, and can be managed more electively, and anticoagulation can be ceased appropriately for up to 6 hours before. Just a couple of things to consider to improve neonatal outcomes is the administration of steroids, magnesium, and antibiotics into the mother. Antibiotics are for prophylaxis against group B strep, which is a common infection in premature babies and carries a high mortality with it. Also determining the place of birth, knowing that birth in tertiary centers has much better outcome for the mom and the baby. So steroids, we well know, reduce fetal mortality in early gestation, more so if earlier on, less than 25 weeks, by reducing respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis in the preterm baby. And the two drugs that are used are dexamethasone or betamethasone, and this is because they have less mineralocorticoid properties and also aren't denatured by the placental enzymes, so they can get to the fetus easily. And optimally, you want to give them within 7 days of the birth, with the course finishing about 24 hours before, but the benefit still remains if you can give it up to 6 to 12 hours before birth. Repeated courses are not recommended. They may reduce morbidity, but don't reduce mortality and might affect fetal growth. Magnesium is used for neurological reasons in the fetus, reduces risks of cerebral palsy and severe motor dysfunction, recommended in gestational ages less than 32 weeks. It's given as a loading dose followed by an infusion, and it's discontinued at 24 hours time if birth hasn't occurred by then. Wouldn't recommend a repeat course, and if emergency delivery has to happen, it shouldn't be delayed because magnesium hasn't been given. The last bit is just making sure that all the equipment that you need is ready right there, close enough to the bedside, including delivery packs, obstetric drugs, the C-section pack, and also things for neonatal resuscitation and management. So to conclude, I would say, just like Kara said as well, understanding the maternal and fetal physiology and how this plays into managing our ECMO patient is important. The interests of the mother, of course, are priority, but the good thing is that translates to good outcomes for the fetus as well. Fetal viability is considered at the 24-25 week mark, and thereafter monitoring may be relevant, but should be coupled with a well-conceived delivery plan. Cesarean section is probably the approach of choice if delivery is indicated, and if possible, it's best to wait for that till the mother is off ECMO. Thanks very much for listening.
I'd like to thank the committee for the opportunity to present this. My background is I'm a cardiothoracic surgeon, surgical intensivist, and a trauma surgeon, so I'm not too bright. Quickly through the review, basically up until several years ago, there really wasn't a lot in the literature about pregnant women, a lot about peripartum, but this is from last week. This is from the ELSO registry, and you can see that worldwide there were 586 patients reported, which represents 4% of all COVID ECMO patients. So going back a few years ago, 2016, Dr. Moore and Dr. Dietl did a review, and up until that time, they only found about 45 patients that had been supported with ECMO that were pregnant at the time. And most of these were H1N1, and they had good survival, maternal survival, not the greatest fetal survival at the time. There was another review done by Dr. Naoun and Dr. Haft and their group from Michigan, And basically, they had 358 women. Again, only about 68 reported fetal outcomes. But again, it tells you that there's good 1-year survival and that this is a reasonable thing to do if you're faced with it. Pretty much the standard complications: moderate bleeding, severe bleeding, surgical intervention, and intracranial hemorrhage. Standard criteria for VV ECMO support. You all know this, although you can do groin cannulation. Basically put a wedge under the right hip, tip a little bit to the left side, particularly inserting your left femoral cannula. That's the one that'll get you into trouble. But you can certainly do this and maintain them on VV ECMO. With groin cannulation, you don't have to go to an Avalon, or you don't have to go to groin and right IJ. It is possible to do this safely. So there was a case report last year, British Medical Journal, again, good result. And so when we got involved with this, sorry, let me go back. Well, I guess I can't. But we're not a university center. We don't have a lot of residence fellows or extra people. We're a 528-bed community quaternary hospital. We have 18 hospitals in our own system, so we have enough people to take care of. But from January 2020 till November 21, we supported 7 pregnant women, PCR positive, COVID-19 with full-blown ARDS. They ranged in age from 22 up to 41, and they were all unvaccinated at the time. The average time for intubation prior to us getting the phone call was about 3.5 days. They all had remdesivir, Decadron, azithromycin, and they were all supported with low molecular weight heparin. The average duration of time that we had our patients on were about 26 days. We did go out to 54. Again, all were groin cannulation and VV configuration. 6 out of the 7 had an emergent or urgent C-section, and 6 out of the 7 were trached in a percutaneous manner. Now, you all heard about all the potential things that could go wrong. I'm here to tell you they do. 6 out of 7 women survived a hospital discharge. We had 1 mortality for a spontaneous intracranial hemorrhage, giving us a survival of about 85%. More importantly, all children survived. All children were neurologically normal and intact, and actually were home before their mothers were. 3 out of the 7 were 3rd trimester, 4 out of 7 were the 1st or early 2nd trimester. And the goal with our fetal maternal medicine and neonatologists were to try to get to 28, 29 weeks. You got to really talk to the family, you got to talk to husbands, you got to talk to potential grandparents. 1st trimester, it is what it is. You know, you use heparin. If there's hypoxia, there's potential end organ damage in the fetus, but it is what it is. 3rd trimester, you push them as far as you can. Generally, you'll get a good outcome. The gray areas in the 2nd trimester, and trying to get them to viability, which is generally 24 weeks, which is accepted. Obviously, our fetal maternal medicine people wanted us to go as far as we could for development. So you got to treat your patient just like anybody else. So that means wake them up, get them up, and move them. So groin cannulation, you can see Mom's bump there. Mom was a little bit shocked that we were getting her up, like, "Doc, is this safe?" I assured her it was, with my fingers crossed behind my back. Fetal monitor, ignore the 98, I did. And low vent settings, 50%. Peak pressure was 31. And so here, just turn up your FiO2 if you need to for exercise. No blood. Housekeeping was very happy. They appreciated that. So Our Lady's 36 years old. She was short of breath for 2 weeks. She was intubated on the 19th. I was called to go to one of our sister institutions on the 20th, went down and cannulated her at a distant hospital, brought her back, did a POCUS on the bedside. RV was severely dilated, however, the left ventricle was working. Started her on some nitric oxide. And the 22nd, she was about 25 weeks and 2 days pregnant. But our neonatologist and our OB nurses, because this is in the middle of COVID, didn't have enough people to spare, so they couldn't do continuous fetal monitoring. So they gave me obstetric ultrasound for dummies and said, here's what you want to look for. So I did daily ultrasounds, I did femur measurements, I did biparietal diameter, and I prayed to God I could find the umbilical cord and see blood flowing through that, but we all learned something new. So she progressed and was moving along, but then she developed gross hematuria, and she also developed signs of HIT. We noticed early on with COVID in our patients in general that there was an increased incidence of HIT, so we switched her over to our Gatraban. So that's her right ventricle on top there. You can see it's dilated, LV's on the bottom, looks like a donut, perhaps a little bit underfilled. Typical COVID x-ray, there are lungs in there somewhere because you got air bronchograms, but they're not contributing to anything. So if you look at the bottom there, you can see that the cannula from the left groin is curved, and that's what you have to be a little bit careful of going up with your guide wire, because you could perforate that. That little white thing is a long 5-French cannula, which is up in the descending aorta as a true central pressure. That was our A-line. So again, moving on, she got fairly comfortable. We were sitting at the side of the bed, getting her up, moving around, trying to get her walking. But then she developed Pseudomonas and Enterobacter in her lungs, and you can guess what happened next. She developed signs of sepsis and low-grade DIC. All anticoagulation was stopped in anticipation of a C-section. I had to convince our OB people that she would go to the OR well, and I went with her. So post-op, immediately she developed shock, and the problem was we had to get her back to the operating room, but they didn't want to take her. They said, this is coagulopathy. I said, no, it isn't. I have a normal TEG. She just had an operation. You got to take her back. It took me hours to get her back there, but in the meantime, kept flooding her with blood products. So what they found at the bottom there is 2 liters of hemoperitoneum, and they said she was bleeding from her rectus muscle. Again, I'm not too bright, but 2 liters of blood from a rectus muscle, 1 and 1 is still 2. That didn't make sense. So again, she kept bleeding, required more blood products. They told me, no, it can't be, it's coagulopathy. Again, show them a normal TEG, show them normal coag studies. They're like, nope, we're done, we're not going back. I'm like, yeah, we are, and you're coming with me. So we compromised, I got a CT scan. Well, all that around the liver, I don't think is ascites, and around the spleen and around the pelvis and everywhere else. So when you look like you're having twins and you just delivered a singlet, I don't know a lot, but I think you need to go back to the OR. So back to the OR we go. Open her up. And what had happened the first time around is that they, in everybody's excitement to help the poor lady, they inadvertently had cracked her liver with a retractor. So we got that under control, packed her open, and got her back to the unit. And so over the next couple of days, we tried to diurese her so that we could get her closed because she had an open abdomen. But again, we woke her up and we're trying to sit her up and keep her moving. As you can see, her blood gas deteriorated, required more blood. Doesn't look optimal here, 55, 56, going the wrong way. But you just keep at it. You do what you need to do to take care of mom. And eventually, that was her x-ray. About 2 weeks later, we wanted to turn her middle name into Pringle. We got her dry. We got her off the ventilator. And this is her 2 weeks ago. They're both stone cold normal.